The topic of discussion is tips and tricks of therapeutic penetrating keratoplasty. So therapeutic penetrating keratoplasty is done for non-healing microbial keratitis, and it is very much important surgery because it saves the eye structurally as well as functionally. So various indications of TPK are large ulcers which progress towards the limbus, involves the sclera, and if corneal perforation is more than 3 mm in size, and large corneal abscesses. Various steps for procedure of TPK are preoperative considerations are very much important: anesthesia, surgical preparation, trephination of the cornea, donor cornea and recipient cornea, then suturing and postoperative treatment. Various preoperative considerations are adnexal evaluation to see where any infection, visual acuity, then B scan is very important to see the status of the vitreous, choroid as well as retina, and status of lens, because it is a major thing which we have to save while we are doing this, and intraocular pressure which we have to control. Preoperative evaluation for depth of the infiltration, we need to precise whether if it is superficial then we can even do DALC in these cases. Extent of infiltrates, imaging of the impending perforation, limbal involvement, if limbal involvement is there any 360° anywhere, then it is the indication, as well as you have to prepare yourself, and associated endophthalmitis or glaucoma. Retrocorneal membranes are very much important, which we can see on anterior segment OCT. Pupillary abnormalities we can see on anterior segment OCT, anterior chamber angle and distortions. Status of the crystalline lens, fundus examination, as well as systemic and topical antibacterial we have to start before. Preoperative assessment can be done with UBM to see the status behind the iris, and anterior segment OCT for angle, anterior chamber angle as well as the lens status. Then B scan we have to do because fundus is neither visible nor it is possible to see, and the B scan can be done to rule out endophthalmitis, choroidal detachment, RDs, and more than 44% of the cases with the more than 2 mm of perforation lead to choroidal detachment. We have to control the glycemic status of the patient. We need to see the serum creatinine level because we have to give the patient on mannitol for the decreasing the vitreous volume, and topical pilocarpine can be also given to maintain the iris lens diaphragm. Donor quality, it can be even if it is good healthy endothelium, it maintains the clarity and involve and lead to less inflammation, and intact epithelium will reduce the infection. And non-optical grade cornea can also be used because it is devoid of the live cells and less steroids are required, and rejection chances are very less. Even B negative can be used for DALC. Tissue suitability, epithelium, anything will go except the infiltrates in the stroma. Endothelial matrix, anything will go, no dropout, it is good. Mild to moderate dropouts and few stress line will go for TPK. Various presentations can be this. Sometimes we can see the popping out of the crystalline lens and vitreous also, and everything is gone, and you just have to open it and do the things. IV mannitol 15 to 20% of IV mannitol 1 to 2 gram per kilogram for 30 to 40 minutes should be given to reduce the volume, and maximum effect happens in 30 minutes. Akinesia, analgesia and hypotony are the key things which we have to achieve. General anesthesia is preferred if larger perforation is there to maintain the arterial pressure, and no ocular massage should be given if we are doing it anyways under perivalvular anesthesia. If small perforations are there, we should first of all we should give the tissue adhesive, and then we can give the blocks. Surgical step, self-staining speculum can be used if there is no perforation, otherwise lid suturing is will go. And Fliringa ring is required because to reduce the pressure, and scleral collapse can be avoided. 360° peritomy if scleral involvement is there, otherwise it is not required. And donor tissue should be, donor size should be always 0.5 mm larger in size. In aphakia we have to maintain 1 mm larger donors. Corneal button should be punched from the endothelial side, and in cases of scleral involvement we can do freehand cutting. Prior opening to the eye, that donor cornea should be refined. Then recipient cornea, we have to do very controlled trephination. Debulking is must if iris is attached with the endothelium of the cornea. Sclerokeratoplasty can be done if sclera is involved in the periphery. And trephination of the recipient cornea, as I have already told, glue should be required if small perforation is there, then we can do trephination, and 1 mm of healthy tissue should be from all the sides. Exudates can be cleared by the side ports beforehand, and with the cyclodialysis spatula we can even remove the iris which is incarcerating. Peeling of the membrane and inflammatory membranes over the iris and angle should be removed. Exudates should be cleared with irrigation with the amphotericin B as well as vancomycin, and depending upon if we have any culture report or something like that. And avoid trauma to the crystalline lens because it can lead to endophthalmitis. It is a good barrier to the posterior segment. Donor tissue placement should be coat the iris as well as the lens with the OVD and then transfer the donor. Then 12 o'clock suture is the first suture, and second suture is the most critical for proper tissue distribution. 4 cardinal sutures are placed, and afterwards we can put 16 sutures or in smaller grafts and 24 in larger grafts. They are always required interrupted with the 75 to 80% of the depth. Longer bites are better for apposition. These are various steps to show whatever I have discussed, and major is that we have to clean the interior chamber of all the exudates, otherwise recurrent and infections are very common. So these are few steps I will be just stretching. This is a Flaringa ring because we don't know what is the status and whether vitreous will come, and then this is definition of the donor cornea. And here we are seeing that here sometimes we cannot take the whole thing together. We have to take the tissue in piecemeal also, because sometimes it is attached with the iris and we have to separate the iris piece by piece. So then suturing is very important. First and second sutures are very important to put, and first suture is very difficult to put, and second is the main which maintains the position of the graft. In the end, the AC should be cleared of all the exudates, of all the membranes. Sometimes it bleeds also if iris is there. It is, we can lead to hyphema also in the end, and we have to do the clearance with the amphotericin B and amphotericin B if it is proved fungal. Lab diagnosis is very much important. Gram stain, QS staining for the recipient graft, we have to send that towards the lab, microbiology lab, blood agar for aerobic bacteria, chocolate for aerobic, and SDA also. So these are few photographs showing. Then complications are RBH, suprachoroidal hemorrhage, expulsive can also be there. And in the early postoperative, wound leakage, shallow interior chamber, as well as persistent epithelial defects, and IOP is the major thing. So post-operative, we have to use preservative-free antibiotics, tear substitute, no steroids if it is fungal till 2 weeks, and oral fluconazole and itraconazole 150 twice, and itraconazole 200 milligram twice can be used. Antiglaucoma and cycloplegics are must in these cases. Visual prognosis, therapeutic success if we have completely eradicated the primary infection, and therapeutic failure is if it gets again infection despite best medical and surgical intervention. So risk factors are pre-existing glaucoma, and if it is fungal, then prognosis is not very good. Larger perforations lead to a worse prognosis and scleral enrollment. So this is just a paper of mine, outcome of therapeutic in advanced infectious keratitis. So perforated corneal ulcer in our subset is the major indication for TPK, 55%. Anatomical success is 85%, therapeutic success is 89%, and functional success in our study was 70%. So indications and complications affect the anatomical, therapeutic, and functional outcome. So these are few pics showing the post-operatives. And so take-home message is the early timing of surgery is critical for good therapeutic outcome, because scleral or intraocular extension of the infection is likely to result in poorer outcome. Thank you.
Thank you, ma'am, for the wonderful talk. Just 2 questions that, yeah, please.
For in therapeutic keratoplasties?
Only interrupted?
No, 10-0?
10-0, 10-0 no.
Because recently in my experience I've seen, I've shifted to 9-0, and I've seen that the suture is equally thin and it has, more strength. Because I've seen after some time in therapeutic, you start getting those peripheral anterior synecdoche.
Yes, yes.
But, and somehow I felt, because the tissue, we don't see what kind of tissue we get in therapeutic. Even there are sometimes edimators. The 9-0 has a better strength. So I've seen that that frequency has decreased when I've shifted to 9-0. So I was asking everybody else's preference. I've not.
I think for the larger graft, if we are doing the more than 10 mm graft, your suture is passing through the sclera, we should use 9-0. Otherwise, for the smaller graft, 10-0 is fine.
Because the only problem with 10-0 is those pass which, after 3 months, 6 months, they start coming. And if the lens is there, the chances are more because of shallow chamber.
So I have no experience of 9-0. I am using 10-0.
And secondly, one more thing, when the infiltrate is big, like more than 8-9 mm, what kind of anesthesia do you prefer?
I always prefer general anesthesia.
Yes.
If perforation is more than 4 millimeter, I don't boast of doing under local anesthesia, because
Without a perforation also.
even without a perforation, yes. If it is more than 6 millimeter in size, I don't go.
That's what I've also
Only
felt.
GA is
that
better.
GAs is always better in large.
Yeah, recently I did one keratoplasty, and that was a small perforation, means 4 millimeter, just a border. I can think of on local anesthesia. But my assistant, I said, no, okay, the patient is not very good, so let us do it under general anesthesia. So when he started draping, lens popped out.
Yes,
Crystalline lens was standing here, and he said, ma'am, it is all gone. Nothing is gone, and vitreous came out. I said, nothing is gone, just hold on, and we have to put then no trephination was required, because it was auto-trephined. Everything came out. Vitreous was there, but vitreous blob was there, and everything was fine. Next day I did ultrasound, everything fine, no endophthalmitis. But yes, we can encounter such kind of things when crystalline lens comes out very easily.
This happened to me. I've also felt the same thing, that these things happen. Although it happens 1 in 30, 1 in 50 cases, but you feel bad when nice case. So GA, or else I've stopped asking assistants for periburbar also. I give a subtenon. That I've seen that it has a less pressure build up than others. Thank you.
Thank you, sir.
I think best anesthesia for the TPK is general anesthesia. Yes. All TPK cases should be done under, if available.
Because your heart is also pounding very high, and patient is also.
And we feel bad when only the tissue is disturbed, rest everything is normal and comes out.
Yes.
It could have been saved.
And even under GA, you should tell the anesthetist that deepen the DA.
Yes. I always tell.
Sometimes they give very mild GA and you are doing the trephination. Yeah.
So in our institute, what is happening, only first year residents is there, anesthesia. He is coming. I said, do you know for what stage I have hired you? He said, no ma'am, you just tell me. I always tell, when I am just refining, I am just starting the trephination, maintain the lower arterial pressure. Then they reduce the BP and then I start.
Yes,
Otherwise, I don't start. This is my first instructions to GA people.
Because they don't use inhalation. Because they think this is a small case, they will not give inhalation anesthetic, so that the faster recovery. So you should tell them we need deep anesthesia.
Yeah.
So very nice presentation.
Thank you.
As usual. My comment is not on the technical part. That's excellent. I'm sure all of you guys are doing very well. The problem, like in your study, you showed more than 50 or 60 odd patients they presented with perforated corneal ulcer. So partly, I think it is our responsibility to educate the general or comprehensive ophthalmologist, because they send it very late. By the time the patient comes to us, it's non-salvage. Then it's like you are wrestling with trying to salvage the globe. So I think we all of us, and especially the senior people, we should try to send out the message, especially for the ulcers. These patients are not, if they are not getting better in best of your treatment, then they should be sent to a cornea person, so that you can save in time before the infiltrate goes beyond 5-6 mm, and you have area for trephination and other things. So I think that's what all of us should focus on.
I think, sir, we should start spreading the timeline.
2 weeks, I think 2 weeks is the maximum time. If it is.
Understand what time is enough time that we should refer now.
So see, the private practice psychology is, यार ये try कर लेते हैं, ये नहीं किया तो ये कर लेते हैं, अगली बारी हो जाएगा, अगली बारी. They do not know, they do not see the end result usually, because by that time they, when it's gone, they come to us. But then we are also helpless. That's the very sad situation.
No, that's very nice.
Yeah.
Everyone should be, really educated when to refer.
Yeah, it's like
but
a mind.
The other point is, even when the treating doctor refers, it's, laziness on the patient's part also.
Yes.
You say go, they will not understand the gravity of the situation. कोई नहीं थोड़े दिन और देख लेते हैं, and when it perforates or something, then they rush, So I think everybody has to be educated.
Yeah, patient is very important, because in these days everyone is so educated, people are also educated, but patient himself They don't want to come to a doctor for any, because they know that they will be saying for something, we have to get the, even surgery, if we are suggesting them, okay, TPK is required, they'll say, okay, हम कल आ जाएंगे, हम परसों आ जाएंगे, फिर वो आते भी नहीं है और बैठे बैठे घर में perforate होके आ जाते हैं, then they come out.
I think sir आपने ये शुरू किया ये.
थोड़ा we have been trying, and the thing is, mostly these patients do not primarily come to the cornea person.
Yes, they
go
don't.
to they go to the comprehensive ophthalmologist or somebody, or maybe some optometrist. So they need to be educated. That's where the real problem lies, because for them it's their patient and they do not want to part with that patient. So that's a very unique problem.
Yes.
So, but time is
Very
the
important.
key. Time is the critical, because the later when it's beyond salvageable, then we cannot do. So I think we can plan something on this line, all of us, and at least spread out a message. Do what I do my here is, whenever somebody sends it, I send that, do the therapeutic, send the patient back to the person. So थोड़ा सा उससे उनको रहता है कि यार patient वापस आ जाते हैं.
That's a very good idea.
Usually I think not me, all of us we do that.
Yes, वो पेशेंट्स आजकल यूट्यूब से देख के, नेट से देख के अपने आप भी ट्रीट करके आए होते हैं, एंड दे डोंट रियलाइज.
That's where the comprehensive and eye care professional, they have a role कि ये अल्सर है, ये नहीं आपसे ठीक नहीं हो रहा है, then it needs some, you know, the patient cannot उसको ये नहीं कि हाँ इससे ठीक हो जाएगा. Most of the time it doesn't.
Slow process.
Yeah.
एक टाइम था डायबिटीज की भी अवेयरनेस थी.
Yeah.
नहीं थी मैम. मतलब over 10 years now every patient is aware कि डायबिटीज है,
Right,
तो जाना ही है.
yeah.
जाना
I think partly
Sir is right.
we
If
need
we start today,
Yes.
maybe 8 years later we can help somebody.
psychotherapy. Yes, exactly. All the
They should throw away their ego. If they should know, I cannot be in the best interest of the patient, I should part with someone. As he said, he sent back to save their ego. So
That's
I
what he
think
said. He said
first of
early
all,
reference.
I've just joined date, but we need to throw away our ego. That is the first thing. So that way you will really be helping the patient. Thank you.
Underlying glycemic status is very important. Sometimes patient doesn't know whether he or she is diabetic or not. When these ulcers don't heal, and we are putting a definition that it is a non-healing ulcer within the bracket of 1 month and all, despite the best therapy, and they are on cocktail, so many of drugs, and nothing, sensitivity is not also even coming on microbiology. Then glycemic status is very important. Sometimes I always do that, for fasting is 400 and patients say, no, I am not diabetic, you are making me diabetic. But actually underlying diabetes is also one of the things which is worsening the status of the ulcer.
You know, there's so much of denial. Recently we had a patient, a very good, from a very big landlord family and known diabetic, पर वो diabetes की treatment नहीं लेनी, and YouTube doctor, and he took something, strychnine type something, and he went into strychnine poisoning. So I think government also should do something. ये जो useless things on the YouTube and anything, that should be banned. They say whatever wherever he studied, wherever he read that and went into it, they said the allopathic medicine cannot cure diabetes. This, what I'm saying, is going to cure diabetes.
Okay.
So,
And they are not medical legally liable.
yes, that is exactly. They hang the doctors. They are scot free.
हम एक गलत दवाई लिख दें तो केस पड़ जाता है. वो कुछ भी बोलते हैं तो वो कोई नहीं होता.
Arey, we are the most helpless people. कोई patient का something goes wrong, the book complications are going to occur. So something goes wrong, a patient dies or something, anything happens, they'll come and, you know, hospital तोड़ देंगे, doctor को beat up करेंगे सारा. And these engineers, now Jalandhar, they've made such bad flyover, so you have to go 1.5 kilometer to Ludhiana side, then take a U-turn to come to Amritsar, and nobody is liable. कितने करोड़ों रुपए लग गए. Then there's one BMC chowk. You reach there and then you don't know which side to go. Every time he asks me, "Appa किधर जाना?" Nobody is liable. Yes.
Okay, so
So sorry for all this, but I think because there are less number of speakers, we can go on with all this.
so I think
Yes.
Dr. Anchal Thakur is not there. Dr. Ashok Sharma is also not there, I think. So we'll move on to